Welcome to the Future of Dermatology podcast. I'm your host, Dr. Farah Kamangar, board-certified dermatologist. Along with being a dermatologist and the host of this podcast, I am also the president of the San Francisco Dermatological Society, which is composed of dermatologists who practice in the San Francisco Bay Area. Every year, we hold our annual SFDerm meeting, and this year we gathered our guests at the Ritz-Carlton in Half Moon Bay. From engaging sessions to incredible food and even a round of golf, SFDerm 2024 was a huge success. Continue listening to hear thought-provoking conversations from our incredible dermatologists who presented on matters that answer your dermatology questions, align with our goals, and provide insight to the future of dermatology. Dr. Mehdi Rashighi, who will be moderating our next session, and he is a physician scientist and an assistant professor in the Department of Dermatology at UMass. He's the founding director of the Connective Tissue Disease Clinic and Research Center, which focuses on treating patients with autoimmune skin diseases, which is what we're talking about today. So I'd love to bring up Dr. Rashighi. Thank you.
Great. Thank you so much, Farah, for the nice introduction. I would like to thank the organizers of the meeting to give me this opportunity. Now I'm going to show you some of the data that we have essentially generated at UMass. So I'm for the most part, what I do, I spend 90% of my time in the lab doing translational research and multiomics. So this was a project that across 4 diseases, patients with psoriasis, vitiligo, cutaneous, lupus, and dermatomyositis, we essentially decided to do multiomics, and for the most part, to compare and contrast the signature in the skin of cutaneous lupus and dermatomyositis, hopefully helping us to identify new targets for treatment. So this is what you see here, essentially the heat map, and I paired with the protein, and the protein here, what I show you is not from the plasma or serum. We essentially directly capture interstitial skin fluid from the lesional and non-lesional skin of patients with these diseases. And what I want you to essentially pay attention is that as we expected, so first of all, I can show you here that in vitiligo, as we had shown previously, so the main cytokines that was highly upregulated was things that are related to interferon gamma at both protein and essentially RNA level. In psoriasis, as you see that we have IL-17, IL-36. So again, these are the things that you would expect to see in psoriasis. But in cutaneous lupus and dermatomyositis, there is a distinct signature that you don't see it in other 2 diseases. And when you essentially interrogate data further, you see that these are the genes and proteins that are directly being induced by type 1 interferon. And as you know, the cutaneous lupus and dermatomyositis are interface dermatitis, meaning that what you see histologically is vacuolar, essentially changes or necrosis of basal keratinocyte. So when we look for our single cell data, you clearly see that there is a very strong type 1 interferon signature, meaning that these keratinocytes, especially when you look at the basal keratinocytes here, so you see that these basal keratinocytes only in DM and CLE and not in vitiligo and psoriasis, they are being highly affected by type 1 interferon. So again, suggesting that this upregulation of type 1 interferon and type 1 interferon-induced genes can truly affect the target cells in those 2 diseases. And measuring those interferon from the interstitial skin fluid from lesional skin of patients with dermatomyositis and lupus, one interesting finding is that, so I told you type 1 interferon has many different members, so it's not one single interferon. But interestingly enough, what you see here is that in patients with cutaneous lupus, for the most part, the upregulated interferon is interferon alpha, and in dermatomyositis, the upregulated interferon is interferon beta. And so at next few lecture, my colleagues are going to talk about the ongoing clinical trial using a monoclonal antibody against interferon beta, and that would be essentially the reason why that seems to be very promising for treatment of dermatomyositis. And also, you might know from this essentially immunology that one of the major sources of these interferons in the tissue, including the skin, are dendritic cells, and there are different subsets of dendritic cells. But when we compare the 4 diseases together, so we clearly see that there is some heterogeneity, meaning that there are certain subsets of myeloid cells that they are more enriched in one disease versus the other. And why it matters is that, so what we see here is that we have this subset of dendritic cell called Plasmacytoid dendritic cell that they are enriched in the skin of cutaneous lupus. And the data from single-cell spatial transcriptomics, you see that all these cells here, each red dot here is one of those plasmacytoid dendritic cells in a section from the skin biopsy of patient with cutaneous lupus. And why it's important is that, so you might be aware that there are currently some clinical trials that are trying to specifically target and deplete these plasmacytoid dendritic cells, and the phase 2 trial has been promising. So that's the rationale behind trying to deplete plasmacytoid dendritic cell as a treatment for cutaneous lupus. And in dermatomyositis, if you see, essentially the most expanded population of dendritic cell is a population called myeloid inflammatory cells. And again, here with single-cell spatial transcriptome, you see all these like red dots, so in the section from the skin of patient with dermatomyositis. It sounds like that in lupus, plasmacytoid dendritic cell, they might be one of the sources of interferon alpha. In dermatomyositis, on the other hand, these inflammatory myeloid cells, that seems to be the source of interferon beta. And as I mentioned already, so there was a phase 2 clinical trial using a novel monoclonal antibody against interferon beta, which the result was very promising. That was for dermatomyositis, and a phase 3 is already ongoing. So that seems to be the rationale why it works. So now I'm just going to spend like a few slides also about some of the research we have been doing about the underlying cause of photosensitivity in cutaneous lupus and dermatomyositis. As you know, in general, most inflammatory skin diseases, we use UV as a treatment. We know that UV does have immunomodulatory effect. The question is that why certain diseases, especially cutaneous lupus and dermatomyositis, they are photosensitive, meaning that UV not only doesn't help to treat the disease, but it's one of the major environmental triggers. So just like a review, so in terms of the spectrum of UV, so UVC for the most part being essentially like absorbed by ozone, doesn't get to essentially to Earth, but we have UVB and UVA, and UVB is the main one, which is almost 100% being absorbed through epidermis. So if you think about diseases that essentially you have a direct effect of UV on keratinocytes, probably UVB is going to be the main wavelength. And so at UMass, we do have IRB approval that in a controlled way, we can irradiate the skin of patient with controlled doses of UVB to see what happened. And I'm just going to show you one example here. So a patient with cutaneous lupus and a healthy matched individuals. So UT is at baseline, so untreated, but then after 1.5 minimal erythema dose of UVB, I want you to see what happens at day 1, day 3, and day 7. So you clearly see that in patient with lupus, one single 1.5 ml dose of UVB significantly induces many of the cytokines that they are known to be induced by type 1 interferon. And also, interesting enough, all the proteins that I've listed here, these are the ones that has been previously shown that they do correlate with the risk of systemic lupus and also lupus nephritis. So that's the reason when we have patients with lupus, we always essentially talk to them. Having unprotected UV exposure can not only induce a flare of their skin disease, but could potentially put them at risk of essentially developing systemic lupus, or if they already have systemic lupus, it might induce flare of their systemic lupus, including lupus nephritis. And similarly, in patients with dermatomyositis, I already showed you that there's a subset of dendritic cells that they seem to play a role in dermatomyositis. What I show you here essentially is that, so this population, this is the same population that I was talking to you about. So without UV, you don't see this population in the skin, but it only takes one single dose of 1.5 mED UVB to see all these cells essentially expanding or influxing the skin, and potentially is going to put patient at risk of having their disease flare up.
These are truncated replays from our original recorded sessions. Join us next year to get the full impact of the SFDerm experience.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.